My name is Dr. Wajiha, and I have passed my Plab-2 exam a month, more than a month back. Today I'm actually joining from the platform of MedExam Expert team, and today's topic of discussion is chest pain. So basically, doctors, you need to understand this thing, that what this exam is about. We know that Plab exam itself that causes a lot of anxiety because itself the exam costs a lot, the fees, the traveling fees, and everything. And yes, it's all about anxiety. The one important thing I really want to discuss today is that once you think and once you try to find out that how to control your anxiety in this exam, it's very easy to ace this exam, believe me. This is the easiest exam that one can actually appear in, and this is the easiest exam that one can actually ace in it. It's all about communication. It's all about how you interact with your patient. It's something you are doing back home. A consultation, which you are doing face to face consultation, interacting with the patient, addressing the ideas of the patient, addressing the concerns of the patient, addressing the expectations of the patient. So, just today's topic is actually chest pain. Okay. So how does this station that comes to you, you know that every station is approximately 8 minutes, right? And you are given 2 minutes outside the station to process the information. Now, what happens that many of the candidates, they take those 2 minutes for granted. They don't process the information that once I'm going to enter the cubicle, once there is going to be a sound that they are going to hear that you now enter the cubicle, what I need to ask from the patient. Those 2 minutes are very critical for you to process the information that what TDs I need to ask from my patient, what life-threatening condition I need to ask from my patient, and what things I need to keep in mind while addressing this patient. For example, if we talk about the chest pain station is basically a station which is categorized as a history-taking station. Remember, even the GMC knows that 8 minute consultation is inhuman. Normal consultation in UK that lasts for approximately 15 to 20 minutes. But what happens that this 8 minutes are very critical for you. It's very important for you to ask important things. Let's the scenario, like when five doctor in an emergency department, John, age 49 years, hospital, please talk to the patient, make history, and discuss relevant examination and appropriate management plans for the patient. Once you're standing outside the hospital, think about this, get the idea that I am supposed to take history from my patient. I am supposed to verbalize the relevant examination and I'm going to talk to the patient about the management. Such kind of scenario is going to be given to me in my exam. That the thing which is actually my point process the information with my that patient is landing in an emergency department. Necessarily, it doesn't mean that pain cannot be
Sorry, we can't hear you, doctor.
Yeah, just a second, guys. Just give us a moment. She'll be back. Dear all, just wait for 5 minutes. Mentor is joining in.
It's all right, no worries.
Yeah, thank you.
Hello, can you hear me? Hello.
Hi, yeah, doctor, we can hear you. You are audible now.
Okay, so till where did I stop?
Sorry?
I mean, where did I stop? Where were the students who not to hear me?
Yeah, you were just started. You can just start now again because we have some new students who have just joined in. So we can start now again.
Okay, I hope there's no problem now going on.
Yeah, hopefully.
Yeah, sorry about the inconvenience earlier.
And thank you so very much, students, for your patience. Let's start again.
Okay, so hello, doctors. My name is Wajiha, and I am talking, and today I'm going to present to you the chest pain from the platform of Med Exam Expert. So at any point, if I'm not audible or by any chance anything happens, just let me know and click in the chat box so that I can see what's going on. There might be some problem in here. I'm very sorry about the inconvenience earlier. Yeah, so we were actually talking about the Plab-2 exam, right? So Plab exam is basically an exam of nerves, as I've already mentioned, right? So all you need to do on the exam day is actually to control your nerves, just to stay patient, just to be calm, because that's how you are going to ace this exam. As I've already mentioned, maybe I don't know if anyone heard about that. It's the easiest exam you can actually come across because this exam is all about concentration. Something which you're doing back home, something which you're doing every day, consultation which is being done, which you do every day back home, right? So everyone knows that 8-minute consultation is actually not possible. If you are completing your station in 8 minutes, means that you are missing something out, right? It's very important. You will pass the station. There are 3 things you need to remember in any station. As long as you have addressed the concerns of the patient, as long as you have come across the patient's patient, as long as you have addressed each and everything the patient is looking for or is expecting from today's consultation, the ICE part. It's the ICE part we talk about in Plab-2 exam, right? Ideas, concerns, and expectations. It's very important for you, address those parts if you really want to be very good in it. And all of you know that the station is divided into 3 parts. It's the data gathering part, the management part, and the interpersonal skills part. Now, what I have seen in the students is that they would be holding notes literally like this, and they would be cramming this in pencils. You don't need to do that. You don't have to extra genius. You don't have to be I don't know which word to be used. You don't have to be extra diligent to pass this exam. Just be yourself, right? Are you following me so far, Mr. John? Are you with me, Mr. John, so far? Are we on the same page, Mr. John, so far? Am I clear so far? Checking on the patient now and then is very important. While you will be doing mocks with us, and many times it's the thing, I have seen students literally sound monotonous. If you get such kind of feedback that you sound monotonous, what does that mean? It means you simply cram those notes and you have just come out to the patient and you have just vomited those notes out. Okay, Mr. John, fine. We are going to do this, 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 this. We are going to pass the catheter, which we are going to do this. We are going to do we are going to check your vessels. Doctors, this is not your duty to tell the patient that. There is a consultant who will tell the patient about the angiography and all that thing. There's nothing which is much more expected out of you as a junior doctor. Just the symptomatic management. That is what GMC is looking for. As long as you have treated the pain of the patient, as long as you have seen that the oxygen saturation is dropping and I need to give my patient oxygen, as long as the patient is vomiting and you have verbalized that I'm going to give you antiemetics, believe me, you're definitely going to pass this exam. For example, this is a very common scenario which is present in front of me. As you can see, you're an FY2 doctor in A&E department. John, age 49 years, has presented to the hospital with the chest pain. Please talk to the patient, history, discuss the relevant examination and appropriate management plan for the patient, right? Now, what happens that you are given an 8 minutes inside the cubicle and you're given 2 minutes outside the cubicle, right? Now, what happens? The students take those 2 minutes very granted. What they do, it's just anxiety. I don't blame students for that. The anxiety, the GMC building, the venue, the Hartman Square, the street, definitely. It's a very nerve-wracking exam, I must say that. But those 2 minutes are very crucial for you to process the information. And by processing the information, I mean that you need to look out what to do. What questions do I need to ask for my patient? What life-threatening condition I need to rule out from my patient. For example, in chest pain, doctors, if a patient is coming to you and saying that I'm having a chest pain, what would be the first life-threatening condition as an FY2 doctor that you would like to rule out? That's an MI. Do you think, doctors, you need to cram these things? It's MI that you have to rule. And based on today's pandemic, COVID-19 pandemic, you need to rule out COVID-19 pneumonia, the MI thing, and you need to rule out pneumothorax and very importantly, pulmonary embolism. These four things, if you are ruling out in life-threatening emergencies and as a DDs, right, you'll pass this exam. Now, what do the students do? Where is the mistake? The students keep on asking the DDs, okay, do you have any indigestion? Doctors, does that make sense? Any patient who's coming to you with a chest pain and it's very clear, it's very evident. And what do the students do? No, the academies told us that you need to rule out 2-3 DDs. Yes, the academies do tell you, but the academies don't tell you that what you need to do is that you need to rule out only the life-threatening emergencies. And you don't need to, ask a bundle of questions to rule out any DDs. What do the students do? Another mistake in this station, right? Okay, I want to rule out COVID-19 pneumonia. Okay, do you have fever? Do you have sweating? And does the pain gets better on anything? Doctors, do you think if anyone is not having fever, doesn't it already rule out the COVID-19 pneumonia? Do you think you need to ask a bundle of questions, that 3-4 questions you need to ask just to satisfy that the academy told you this thing, that you have to rule out this thing? Does that make sense, doctors, so far? Okay. So, okay, right. So, like that, as I was telling you, that in 2 minutes you have to stop.
Hi, Dr. Wajiha, you're not audible again. Hi, we can't hear you actually.
Guys, am I audible now?
Yeah, thank you. You are audible now.
Okay, so where did I stop? Can anyone tell me? Hello, doctors. Any one of you, till where did I stop?
I guess it was just 2 seconds before you just stopped.
Right. So like I was telling that any patient who is landing in A&E department, it means that the patient was actually in a very severe pain, that the patient has landed to you in an extended emergency department. Means that the first thing outside the 2 minutes when you're standing outside the cubicle, right? You need to think that the patient has landed in an A&E department, means that the patient might be having a severe pain. That's why the patient has presented to me in A&E department. Very important thing I need to rule out is that I have to rule out an MI. The second most important thing is a male person, right? Males are comparatively at more risk of developing an MI. Right, okay, John, right, maybe a male having an MI. Age 49 years, again, in age is an important risk factor for having an MI. So this is the most important thing. So when I will be standing outside the cubicle, what I would be doing is that I would be making sure that I rule out MI. However, I will keep in mind that pulmonary embolism is also my DD. Pneumothorax is also my DD. Also, I'll make sure that I rule out the COVID-19 pandemic, right? So how you begin this station? You enter the station once it's announced that you may now enter the cubicle. As you enter the cubicle, always greet your patient with a smile, right? Be a good doctor, be just a smiling doctor, unless and until it's a Breaking Bad news station, right? Breaking Bad news station, don't enter with a smile, right? But make sure that if the patient is in pain, empathize with the patient. Now, where do the doctors again make the mistake and they sound monotonous, and every other doctor is repeating the same line? Okay, the patient is coming to you, doctor, I'm having a lot of pain. Okay, Mr. John, I'm here to help you. My name is this, and I'm one of the doctors working in this department. I'm here to help you. Mr. John, are you comfortable enough to talk? Should I offer you some painkillers before moving on towards the consultation? Usually the patient will say, okay, fine, doctor, I can bear. Or maybe the patient says that, okay, one of your nurse colleagues has actually given me the medication for that. Empathize, okay? Little pain, even the patient is presenting to you with the pain, make sure that you empathize with the patient. What do the doctors do? Okay, you are having pain, so tell me about it. No, doctors don't do that. Okay, Mr. John, I'm very sorry to hear about that. You have been very difficult for you, must have been very tough for you, but I'm here to help you. Me and my team are here to help you, and we will make sure that we try out every possible thing to make you help and relieve your pain and try the best we can do. Do you think, doctors, you need to cram these sentences? It's just empathy that you're showing, right? Every other thing that you are doing and everything that you're doing. Am I audible so far, Mafia? No?
Yeah, doctor.
Okay, that's great. Right.
Yes, doctor. Thank you.
Yeah, thank you so much. So what do the doctors can make mistake here, right? Okay, so where pain start? No, doctors don't do that. You need to start your question from an open-ended question. Okay, Mr. John, I'm very sorry about your pain. Can you please tell me a little bit more about your pain? Right. Okay, pain started 2 hours ago. Pain is very bad. The pain is very severe. It looks like that usually what the patient says is that it looks like that an elephant is sitting on my chest. So see, acute onset of pain, the patient will give you a lot of information. You need to extract that information. If you repeat what the patient has already told you on your mark sheet, the day you will get your results, you will be marked in listening, which means that you have not listened to the patient properly. Try to listen what the patient is saying. So, patient said that it started 2 hours ago and it's a very severe kind of pain, right? Looks like an elephant is sitting on my chest. Doctors, if the patient is telling you that this patient is so severe, you think you need to ask the patient to scale the pain? No, don't do what every other doctor is doing in that building. Don't do what every other student has crammed those typical sentences that academies have teach you and you try to vomit those sentences out. Don't do that. The only way you distinguish yourself is listen to the patient. Try to ask the relevant thing. So what we do is that is that we apply Socrates to the pain, right? Where exactly is the pain? The point when the patient will tell you about the site where exactly the pain is, that will give you a lot of pain. It's right here in my chest, right? Usually, this is a differentiating point, right? If the patient, if it's a diffuse kind of pain all over the chest, it's more likely to be a musculoskeletal pain, right? But if it is more localized on the left side, it's more likely to be associated with an MI pain, right? Then we ask about, okay, Mr. John, how does pain start? That's the onset, right? MI pain is an acute pain, right? Musculoskeletal pain is a more diffuse pain, right? And it's more of a gradual onset. What kind of pain it is, right? That tells you about the character. Okay, Mr. John, does the pain go anywhere? Yes, doctor, this pain goes to my left arm, it goes to my left jaw. But however, sometimes MI pain doesn't go anywhere according to the new recommendations and according to the new things. The MI pain can or cannot radiate, but still, for the R thing, we also go for the relieving factors. Is there anything, Mr. John? Have you tried anything to make it better? Yes, doctor, I tried taking paracetamol, didn't get better with that. Again, that's a hint. If it would have been a musculoskeletal pain, that would have got better with the, painkillers. Just because it's an MI doesn't get better. Okay, Mr. John. Um, is there anything else associated with that? Now, here is again one mistake doctors make. What they do, okay, doctor, I feel sick. Okay, what they do, they will start applying all or para to that. You don't need to do that, doctors. Pain is your initial complaint. Try to explore the initial complaint. If the patient has a secondary complaint, it's okay to apply Odipara to that, but don't waste your time. Okay, when did it start? How did it start? What did it happen? No, doctors, don't waste your time. You just have 8 minutes to complete the station, right? Just be very vigilant when you're doing that, okay? Okay, so do you think it might be associated with that, Mr. John? Okay, that's it. And by any chance, have you vomited? That's it. No more questions, okay, for the nausea thing. When exactly this pain started? Does the pain comes and go off? For the T thing, that is the time. Does the pain gets better? It's already worse, doctor. Nothing is making it better. Nothing is making it worse. It's already the worst pain I have, right? And on the scale of 1 to 10, if the patient is already saying it's the worst pain, don't ask the patient to scale the pain, right? That sounds very vague. That sounds very scripted. That sounds I don't know what else I can use for that, but it sounds very scripted, right? Once you have applied Socrates to the pain, now rule out the DDs, right? I told you only life-threatening DDs, right? No need to ask a bundle of questions. Okay, Mr. John, do you have fever? Fever will rule out your COVID-19 pneumonia. It will rule out your pericarditis. That's it. Pericarditis done, COVID-19 pneumonia done, right? Do you have any cough pain? DVT already ruled out. Pain breathing will already rule out your pulmonary embolism and your and cough. 4 questions. Enough. No need to go into further details. Okay, you feel the skin titration. Okay.
Sorry, doctor. I think your audio is going again.
Is it okay?
Yeah, it's fine now.
Yeah. So what happens? It's 4 questions, right? Fever, cough pain, difficulty in breathing. Cough. No more. No
Sorry,
indigestion.
not audible again. I think there's something to do with your wire, the headphones wires.
Is it okay now?
Yes.
Right. So what happens that you don't need to ask a number of questions, right? Just 4 questions and that would be enough, right? That's the fever, the cough pain, the breathing difficulty and cough. 4 questions and you are done with DDs, right? Don't ask too many questions. Is that okay, doctor? Am I audible now?
Yes, it's perfect.
Right. Okay. So once the DD is done, what happens? Mr. John, has this episode ever happened before? Why do we ask this question? That why it has happened before. A patient who's landing with an MI will tell you something that maybe he was having some chest pain, he was having some retrosternal burning to which he never paid attention. Maybe, yes, doctor, it did happen. I never paid attention to that. Got better when I rested, but I never paid attention to that. I never paid, visit to the doctor, right? So that's an again hint. Why do we ask this question? Has this ever happened before, doctor? Has this ever happened before, Mr. John? By any chance, this has ever happened before, right? Okay, that's done, right? Okay, so another thing you have to ask here is about the past medical condition. Now, what do the doctors do? Again, I'll tell you what do the scripted doctor do. Okay, Mr. John, do you have any past medical condition? What past medical condition? Okay, I fell 1 year back. No, don't do that. Always ask the relevant medical condition, right? For example, if a patient is presenting to you with an MI, right? What could be the risk factors for this patient? Any patient who's having diabetes is at the risk of developing an MI. Any patient who's having high cholesterol is at the risk of developing MI. Any patient who is hypertensive is at the risk of developing MI, right? So don't generalize the question which every other person is doing in the exam. Try to be more specific. Mr. John, have you ever been diagnosed with diabetes? Or have you been ever diagnosed with hypertension? Or you have ever been diagnosed with high cholesterol? Okay, now what do the doctors do? Okay, doctor, I have diabetes. They will move on to the next question. Don't do that. Don't do that, okay? Okay, Mr. John, apply the 4 Ps to that disease. Since when do you have the disease? How are you controlling this disease? What medications are you taking for that disease? Did you visit your GP regularly for that disease, right? Again, this will give you a hint. Patient is diabetic, patient is non-compliant, patient is not visiting GP. It means that he's at the more risk of developing an MI. Is that clear so far, doctors? Do you think you need to be extra genius to understand these conditions, or you need to understand these things, or you need to cram these things? Isn't this easy? This is easy, right? Okay, now again, every other doctor would do, okay, doctors, no, DESA is an important part. I need to ask about the diet. I need to ask about the exercise. And I need to ask about the MEFTOSA part as well, because that's what is written in the script, right? That's what academies are teaching you. No, just imagine, doctors, God forbid, all of you, I hope, get a very good health, but God forbid, if by any chance you land in an emergency with an MI pain and the doctors ask you, okay, can you walk me through your diet? How insane that sounds, doesn't it? That will make you look more scripted. That will make you sound more monotonous. Don't do that. You can omit the diet and exercise part, right? However, what you will do in this station, what will distinguish you from the rest of the candidates, okay, Mr. John, there are a few risk factors that we have to discuss, out of which diet and exercise is very important. How about, Mr. John, that once you're going to get stabilized, once you're going to get better, how about we discuss that when you're going to get discharged? See, this will make you, the examiner will know that you know that diet is a risk factor. Exercise is a risk factor, but just because it's an emergency, MI is an emergency, you will not treat ST depression, you will not treat ST elevation, the patient is going to die anyway. But believe me, diet and exercise is something you need to address once the patient is stable, right? Does that make sense? Yes, you can ask about the smoking part, you can ask about the alcoholing part, but not much, right? Do you smoke, Mr. Alcohol? Okay, since when what do you smoke? Okay, what do the doctors do? They assume that patient is smoking cigarettes, right? No, patient do smoke weed as well, right? This happened to me in my exam. I assumed that the patient smoking cigarettes, and the patient said me that, who told you that I smoke cigarettes? I smoke weed, right? So ask, what do you smoke? Since when you have been smoking? How many cigarettes per day? Okay, how about this, Mr. John? Once you're stable, and we discuss that towards the end, I know that it's very difficult for you to give up the smoking, and it takes a lot of nerves to give up smoking and to quit smoking. How about once you're going to get stable and we are going to discuss that? See, more natural, sounds more good. Does that make sense, doctors? And again, alcohol. Since when do you drink alcohol? What do you drink? Since when you have been drinking, and have you thought about quitting it down? That's it. Again, I told you that diet and exercise, don't do that. You can mention that, but you can say that, Mr. John, once you're going to get stable, we will discuss that in detail. Can I ask about smoking? Okay, doctors, can we take it, the questions at the end, if you don't mind, please? I'll answer that question shortly, right? So you can always talk about that, right? This will distinguish you from the rest of the candidates, right? Patient is an A&E department, not necessarily in A&E, diet and exercise is something you're not going to look for, right? The other thing is meftosa. Okay, what do the doctors do again? Okay, oh, I need to ask the T part. I need to ask about the occupational history. I need to ask. No, you don't need to do that. There are certain stations where you need to ask the travel history. There are certain stations where you need to ask occupational history. There are certain stations where you need to ask the sexual history. If you don't ask that, you will fail the station. For example, the station of STI, sexually transmitted infection. If you don't take the history, you will fail the station, right? If the patient has undergone angiography and he's recovering from that angiography and you don't ask the occupational history, you will fail that station, right? If the station is of tuberculosis, you don't ask the travel history, you will fail that station. But believe me, what do the students do again here? Do you have any stressors at your home and your work office? Does that make sense, doctors? No. Patient is in A&E department. What are you going to do about the stress anyway? Okay, so don't do that. Do ask about the medications. Do ask about the allergies. Do ask about the family history. That's it. The math is important everywhere. Any kind of medications you are on, any medications like over-the-counter medications or any antibiotics that you're using, any allergies, Mr. John, that I should be aware of, and anyone in your family who has been diagnosed with a heart attack. And once you have finished the history, anything else means, okay, Mr. John, I thank you. Now what do the doctors do? Once they have taken the history, they will just rush towards verbalizing the examination. No, thank the patient. Thank you, Mr. John, for talking to me, for being so patient. I know that you are in a lot of pain, but thank you so much. I really appreciate your patience. You have been so patient to me so far, but I'll try to help you as quickly as I can. See, more natural. You sound good. You don't sound scripted, right? Okay. Right. So once the patient is coming to you, once you have done with, you have thanked the patient at the end of the history, do that, right? And you know, doctors, how you need to be flawless in everything. It's not just the data gathering, it's not just the interpersonal skills, it's not just the management where you have to be flawless. You have to be flawless in everything. Practice these things, you know, the P1, the P2, the DESA part, the meftosa part in front of the mirror, and practice it as much as you can. Because I have seen students struggling. They think that what question I need to ask for. No, 8 minutes, you shouldn't be asking about the other question that you need to ask for. It should be on your fingertips. Okay, this, and that's it. You'll get more time to involve the patient. You'll get more time to address the concerns of the patient, right? So what are the relevant examinations that we need to do? What do the doctors do here? Again, an important part. They never verbalize the oxygen saturation, right? This is one of the important thing, you know, that don't you think, doctor, if the patient, his heart muscle is dying and you don't verbalize oxygen saturation, how terrible you will look, how scripted you will look if you don't verbalize oxygen saturation. Doctors don't do that, okay? And okay, Mr. John, I would like to check your blood pressure, your pulse, your temperature, and I would also like to check your oxygen levels. See, this will make you different from the rest of the people. It will sound you more natural, it will sound you more knowledgeable, right? I need to go for the examination of your heart. I need to listen to your heart sounds. I need to listen to your chest. And don't say, I would like to do general physical examination. Just say, I will go for a head to toe examination to see that if I can see anything, right? Once you have verbalized the examination, now investigation, right? Now, again, doctors, any person, you know, people in UK are more educated, right? They will come and teach you what's going on with them, literally, right? But in our countries, in our home countries where people do not have much knowledge and use the term ECGs and troponins and electrolytes, you have to use the layman term, right? Instead of ECG, use the word, I'll go for the tracing of your heart to see that if there are any kind of the changes. I'll double check with my seniors to make sure I have not missed any findings, right? So instead of saying that I would be doing an ECG, right? Say that, okay, Mr. John, I will be going for the heart tracing to find out any kind of the changes in the heart. I will go for the heart enzymes, right? To check that what's going on with you. I will be going for a full blood count to check for any kind of deficiency of your blood, right? You know, anemias, we have to rule out anemias. I have to check the mineral levels in your body, which are the serum electrolytes. I have to check your cholesterol, your random blood sugar, your kidney function test, and your liver function test. So doctors, what do the doctors do, right? Now, this is an important thing. You don't, heart tracing is, everyone knows that they need to do that. And it's very important for you to pass the station as well as heart enzyme. But again, what do the doctors miss? They don't verbalize the cholesterol and not find the random blood sugar. If you don't find out the risk factors, doctors, how are we going to come to know what's wrong with the patient? You don't treat the cause. How are we going to find out that what initially caused a heart attack in the first place, right? So verbalize these things, right? This is very important. Random blood sugar will give you an idea about his diabetes. Maybe not, it was not diagnosed before, but maybe he has diabetes for now, and that was a risk factor, he's having an MI, right? Does that make sense? Okay. Okay, so, you need to divide the management. What do the doctors do? They will tell you a very haphazard management, right? Always begin by saying that whether you are going to admit the patient, whether you are going to observe the patient for a couple of hours, or you're going to discharge the patient. Okay, Mr. John, it looks like you're having a heart attack, right? And then the patient will burst, okay, doctor, what? I am having a heart attack. How is it possible? And how? Just counsel the patient. Okay, calm the patient. I know, Mr. John, it's a very tough time that you're going through, and it's a lot to take in as well, Mr. John, but we are here to help you. We will help you in every possible way. But what is actually happening, that there is a blockage in the vessels of your heart, which is reducing the blood flow to your oxygen. And that's why you're having chest pain. At least tell the patient why he's having chest pain, right? The doctors will cram that sentence, which is written in the notes. Okay, there's a blockage in the blood vessels. Your heart is not getting enough oxygen. Your heart is not able to pump the oxygen, right? At least tell the patient why he's having chest pain, right? Just because the oxygen to your heart muscle is reduced, that's why you are experiencing the worst chest pain of your life. Does that make sense, Mr. John? Are you with me, Mr. John? Are we on the same page, Mr. John? Are you following me so far, right? We might have to admit you, or we might have to observe you for a couple of hours till your heart enzymes come back to us, and then we'll make a decision based on that. Is that okay, Mr. John? Do you want anyone to give a call? Is there anyone with you right now, Mr. John? Do you want anyone to give a call right now? Look, that's how you are telling the patient what you're going to do. At the same time, you are boosting your interpersonal skills as well, right? And then as a FY2, just Mona. Don't say we are going to pass the catheter to your leg and then we are going to pass into your heart. We are going to open. This is not your duty, doctors. There is a consultant, right, who's going to explain everything. Don't do that, okay? That's not your job. Even if the patient asks, just tell him that, Mr. John, I'm not the right person to talk to, unfortunately. I don't have much information about that. However, I can assure you that you are in the best hands. And one of my consultants and one of my senior members will come and talk to you about the procedure in detail, and they will address you every concern that you have. See, this will make you different. This will sound unscripted. This will sound you less monotonous, right? So you explain the patient that for now, Mr. John, I am going to give you oxygen, which is going to be, I'm going to give you through the mask. I'm going for your pain, Mr. John. We are going to give you a stronger painkiller, which is morphine. We are going to give you nitrates so that if there is any kind of blockage, right, it gets improved with that. And then we are going to give you aspirin, which is the blood thinners. Once you're going to get better with all these things, right, we would repeat an ECG after half an hour, and we'll see what we can do. I'll page my seniors on board and see if there is anything else to be done. And once you're stable and once you're going to be fine, we will refer you to a heart specialist for further medications and change in medications according to the test results. Do you have any concerns so far, Mr. John? Okay, now what do the doctors do? They address the concern in between. They ask the concern at the point of where P2B. It's up to you, doctors, right? But make sure that check on the patient now and then. If you're checking on the patient now and then, you're all good to go, right? Address the concerns, right? Okay, doctor, why? The concern mostly in this station is, doctor, why did I have that? Mr. John, you told me there are a couple of risk factors, Mr. John, which among of them which can be diet, exercise, smoking, and alcohol. But Mr. John, we are first going to stabilize you, and then we'll discuss about all these risk factors in detail, and we will guide you appropriately that how to avoid such things in the future. But now, Mr. John, it's very important for us that we stabilize you. Right, doctors? Is that clear so far? Okay. Is that clear so far, doctors? Hello? Okay. Thank God, it's I'm still audible, which is quite surprising for me at this moment. Okay. So, sure. Okay. I hope this ACS station is actually done, right? So doctors, please make sure in mind, right? Don't cram the sentences which are given in your notes, okay? Don't, just be natural, right? It's everything. Believe me, you are all all of you are great doctors. You're all empathetic doctors. You're all very kind-hearted doctors. That's the reason you have chosen this profession, right? Just be yourself. Just try to keep yourself in that position or any of your relatives at that position and see what you will do in that situation. Everything is going to be so natural. It's going to be so fluent that it will actually distinguish you from the rest of the candidates, coming from other academies, right? This will definitely distinguish you, right? You just have to be yourself. You just have to be fluent, not a single thing. You have to be flawless in everything, right? The second station we are going to discuss today is pericarditis, right? Now, there is another important thing that academies won't teach you, right? But this is going to distinguish you from the rest of the candidate. Now, what is pericarditis? It's actually the inflammation of the pericardium. Usually, it again comes with that you are an FY2 doctor in any department. Okay, John comes to you, chest pain, try to explore that chest pain, and that's right. If you will go through station one by one, you'll make your life harder. Just try to stick to the structure of the station, right? Pericarditis, musculoskeletal pain, ACS, pulmonary embolism, right? Transgender chest pain. And one is like chest, there's a new station like chest pain mastectomy, right? There are all other stations as well, right? But you need to follow a structure, right? If you will follow your structure, if you will generalize your station, that will make your life easier, right? So again, pericarditis station will begin normally as, the ACS station will begin, right? Apply Socrates to the pain, rule out life-threatening DDs. Now, normally in pericarditis, the patient is having chest pain, but the chest pain gets better on bending forward and is worse on lying down, right? So this is the biggest hint the patient will give you, right? Once the patient has given you about the SOC, and begin your question openly, as I've already mentioned. Don't start with closed question. Where did the pain start? Tell me more about it, right? Once you've applied Socrates to the pain, once you have ruled out the life-threatening DDs, has this ever happened before, right? Any fever, flu-like symptoms is very important, right? When you will ask about fever, I said that fever and trauma, these are the two DDs which you can fix in every station. Believe me, fever means you rule out inflammation. Trauma means you rule out trauma itself. Fever and trauma. If you don't remember anything, it's a new station. You are unaware of anything. You don't even know ABC of that station. Just try to add fever and trauma in that station. That would be considered as your thesis. Has this ever happened before? Any medical condition you have been diagnosed with? Now, doctors, what do they do? Do you think pericarditis has anything to do with diet? What do the doctors actually do in pericarditis? Can you quickly walk me through your diet? That sounds very scripted, doctors, believe me, right? Exercise has nothing to do with pericarditis. Okay, for God's sake, don't do that, right? Don't ask about diet, don't ask about exercise, right? Be realistic, right? If anything you are asking, anything that you are asking that needs to make sense, right? So that's again one of the things, right? So don't ask about diet. You're saving your time. The more you're trying to compress the information, the more logical you are sounding, right? Ask about the smoking, ask about the alcohol as well, because that's an important thing you need to rule out. You try to rule out many risk factors by asking smoking. Now, what happens, right? Doctors don't ask about the drug history, IV drug history, right? No academy will teach you this, but believe me, intravenous drug abuse is one of the risk factors for the pericarditis, right? So if you don't ask that, if you ask that, you would be given plus points. If you don't ask that, maybe you pass the station, right? But if you ask that, that will sound you different from the rest of the students, right? So when you are taking IV drug history, what you're going to ask, Mr. John, the question that I'm going to ask, that might sound a bit uncomfortable, but that is just a part of consultation, Mr. John. Is it okay for me to go ahead? Yes, doctor, sure. Mr. John, are you using any kind of IV drugs? Don't make make use of the word abuse, okay? Don't use that. You need to sound a little empathetic to the patient, right? Mr. John, are you using any kind of drugs? Which drugs are you using? Which route do you use to administer those drugs? And do you exchange needles? Have you heard about needle exchange program? If not, then tell the patient about the needle exchange program. That needle exchange program is a program where your old needles get replaced by the new needles so that you don't catch any kind of bloodborne diseases. See, doctors, this is going to distinguish you, right? This is going to sound you, I don't know, if I would have an examiner, I would definitely have awarded great marks to that student asking about the IV drugs, right? And then ask about the medications, the allergies, the family history, right? Again, travel history is not that important, right? Occupational history is not that important. Social history is not that important. You can miss, if you have time, you can ask that. It's up to you, right? Recent viral illness, you can ask at the point where you were asking about the fever thing, right? When you were asking about the DDs, any past illness or any fever or anything like symptoms you had before, right? And yes, once you are done with your history, thank the patient. Thank you, Mr. John, for keeping up so long with me. I know I have taken a lot of your time, but thank you so much for being so patient. Now, if it's okay for you, I would like to examine you. During my examination, I would be checking your blood pressure, your pulse, your temperature. I would be going for a head-to-toe examination. I would be looking to your chest, and I would be looking to your heart sounds as well, if that's okay with you, Mr. John. Yes, doctor, that's fine. And then they usually hand you over some findings as well, right? Okay, Mr. John, at this point, I need to go for some tests as well, right? Doctors, if you don't verbalize inflammatory markers here, believe me, you are not going to pass the station. This is pericarditis, right? It's the inflammation of the pericardium. You're not going to send ESR, you're not going to send your CRP, they're going to deduct you. Yeah, they are going to deduct your marks. You talk about electrolytes, you talk about random blood sugar, you talk about cholesterol, they are not that worth in this station, right? But if you miss this thing, right, this inflammatory markers, ESR, CRP, the tracing of the heart, your full blood count, your kidney function test, your liver function test, you will not pass this station. Does that make sense, right? So this is, and right, so once you have told about this one, right, so management, right? Now, how you can distinguish yourself from the rest of the candidates while talking about the management, right? First, do you have any idea, Mr. John, what's going on with you? No, doctor, I don't have any idea. Have you ever heard of the term pericarditis, Mr. John? No, doctor, what is that, right? Okay, Mr. John, there is actually a covering around your heart. And because of any kind of viral illness, that pericardium usually gets inflamed, as a result of which you have chest pain and you have fever as well. And that's, I am suspecting. Okay, don't be sure about your diagnosis. Just say, I am suspecting it to be pericarditis. However, I need to double check with my seniors, right? Doctors, GMC wants you to know your limitations, okay? Don't do anything which is beyond your limitation. Ordering CT scan is not your domain. Ordering a chest X-ray is not your domain. Just giving symptomatic treatment and maybe a little bit baselines, right, which are required, is your domain as an FY2, as an SHO, right? But ordering some investigations, they are not your domain, right? So Mr. John, we are going to give you some NT, just because it's an inflammation, we are going to give, talk to the patient in a way they can understand why you are giving such medication to the patient. Mr. John, as I mentioned, that it's the inflammation of the sac. So we are going to give you anti-inflammatory. Does that make sense, Mr. John? We are going to give you some painkillers, which are not only going to reduce your pain, but they're also going to reduce your inflammation. And these non-steroidal anti-inflammatory drugs sometimes can cause stomach upset. Therefore, Mr. John, we are going to give you some stomach protection with it. That is the antacids with that. We will see you in a period of 2 weeks time. You have to come in a period of 2 weeks time, and then we'll see. If the pain doesn't get better, then we will be adding another other painkiller, which is colchicine. Still, if it doesn't get better, then I'll double check with my seniors to check what other options are done. Now, what do the doctors do? You know what? Literally, I've seen doctors doing this. Cardiac tamponade is a complication of pericarditis. Just because they have learned in their scripts, just because they have crammed in their scripts, what do they do? We'll pass a needle through this bone and it will go up and it is going to drain your fluid. No, doctors, this is not your job. This is not your job, right? Don't do that. Okay, all I will say that, just don't do that. Scripts and notes mention, right, about the tamponade and about all these things, but you don't need to do that. Just try to keep it as simple, as subtle, as simple as you can. Make your life easier. Don't make your life hard, and don't make your life hard for your patient as well. Just do this, okay? Right. Okay. Usually in the chest pain, we do have 6 stations, right? But it was just, I prepared for the 3 stations, right? Because we have some time shortage as well and some time limit as well. And if I get another chance, definitely I will be doing the 3 stations, and maybe if anyone wants to do an interactive station as well. Right, so, okay, so we have another station, right? Is everything clear about pericarditis? Do we have any questions about pericarditis thing?
Yes, thank you, doctor.
Okay. Okay, so, okay, the next station is the musculoskeletal pain, right? So it's again, I told you, just generalize the station, right? Apply Socrates to the pain. Now, what the patient is going to give you a history in this, that this was, gradual onset. I lifted, doctor, I lifted something heavy, and I think I have hurted my back, and that's the reason. The patient will tell you on his own, right? It's a very easy station, right? The patient will tell you, I lifted something, I got hurted, the pain has started, and now it's not going anywhere. I have tried. Now listen to it, doctor. What do the doctors do? Here they make a mistake. The patient will tell you that he has taken paracetamol for the pain, but the pain is not going anywhere. And when they will tell the management doctors, they will say that, I will give you some painkillers that is paracetamol for you. And you know what? The patient will backfire. Doctor, I told you earlier that the painkiller, the Panadol, that didn't help me, right? So listen to the patient. If patient is taking paracetamol for 1 week and the pain is not going anywhere, try to step up, right? This is something you have to do, right? And that is only possible if you have a control on your nerves on that example, right? Just move a bit step. Okay, doctor, Mr. John, you mentioned that paracetamol was not helping you, right? So how about I offer you a stronger painkillers which can help you with that? Excellent. There you go. Best. That's it, right? Patient will be satisfied, or examiner will be satisfied, right? And definitely you will get marks for that, right? But repeating paracetamol will make you just lose marks, doctor. Don't do that, right? So once you have applied Socrates to the pain, you have applied, rule out life-threatening DDs, because in Plab, there is one of the stations where the musculoskeletal pain was actually an MI and gets misdiagnosed, and there is an angry patient that lands in emergency and saying that a fault has been made, right? So be a safe doctor. That's what GMC wants you to be. Try to rule out all DDs of an MI, right? Does the by any chance any nausea, vomiting? By any chance the pain, any nausea, vomiting, any breathing difficulty, any fever or flu-like symptoms, and any cough pain? The 4 questions I've told you for chest pain, that's enough. Will make you rule out your life-threatening emergencies, right? Has this ever happened before? Medical conditions, do verbalize diabetes, cholesterol, and the diabetes, cholesterol, and hypertension. Diet is again not important. Musculoskeletal pain, yes. Exercise is important, right? Patient will tell you earlier that I tried to lift up everything, or I tried to lift up heavy thing in my gym, and that's why I have tried to, I have this pain, right? So exercise is important, right? Smoking, you can ask. Alcohol, you can ask, because again, they are important risk factors. You can ask about medications, allergies, family history. Now, it's very important, doctors. Psychosocial history is very important, right? You need to ask the patient about the occupation. What will happen if you don't ask this? The patient is having musculoskeletal pain. He's in a lot of pain. Even the musculoskeletal pain hurts a lot.
If you will not ask the psychosocial history, you don't give an option of the patient for the help. Do you think it will help you boost up your interpersonal skills? Mr. John, may I ask, who do you live with? Do you have any help available at home? Do you need any kind of help from our side? See, your interpersonal skills, way up, right? And what kind of work do you do, right? You need to abstain the patient from lifting heavy things for at least a week in musculoskeletal pain, right? So what if the patient is working at a warehouse? Do you think the examiner will pass you in this station if you don't ask about the psychosocial history? It's very important, right? Maybe you can give sick note to the patient. Maybe you can say that I can contact occupational health department. They can make some necessary changes. They can talk to your employer. They can make some necessary changes, right? When you return back to work, so things get easy for you and you don't end up in such pain again, right? Still make sure to rule at MI. Usually musculoskeletal pain does not require any investigations, right? But still, be a safe doctor and do verbalize. I would like to check your blood pressure, your pulse, your temperature, your oxygen level. I would be listening to your heart, your lung sound. I would be going for a head to toe examination. Additionally, I will be going for heart tracing and some heart enzymes as well, right? That will make you, and however, I will double check with my seniors, right? Right. So, Mr. John, you mentioned that it looks like that it was just okay. Ice part is again. You can address the concern at any point. Usually, people address the concern at the point where they ask about the P2B, right? But you can address the concern at any point. That's totally up to you, wherever you feel comfortable. But make sure concern is very important. The concern of the patient in musculoskeletal pain will be he's having an MI, okay? But empathize with the patient, Mr. John. I can understand it must have been very difficult for you to be in this kind of pain for such a long time. But I have done tracing of heart, and as a part of reassurance, I've also sent some heart enzymes, and everything is quite reassuring at the moment, right? However, your concern is definitely valid, and I would be double checking with my seniors to make sure if everything is okay with you. Once we are sure everything is okay, only then we are going to send you back home. How does that sound, Mr. John? Does that sound reassuring? Does that sound good, Mr. John? See, there you go. And you say that, Mr. John, you mentioned that paracetamol is not helping you. We'll give you some stronger painkillers. But Mr. John, the painkillers can sometimes cause you a gastric upset, right? They can cause a stomach upset, right? Make sure that you take plenty of fluids while you are taking painkillers. And I would be also giving some stomach protection, which are the antacids, right? Meanwhile, you can take your rest. I can offer you a sick note, and I can contact occupational health department for you as well. Do mention about the ice packs as well, right? But you know what will make you score more? Okay, Mr. What would the doctors usually do? Okay, you can use ice packs, right? But you know what will the good doctors do? They will say that, Mr. John, don't apply ice packs directly to your skin. You can burn your skin, right? So make sure you put a cloth underneath, and then you can use your ice pack. At any point, if you feel like your pain is not going anywhere, you're having breathing difficulty, or you are having the worst pain of your life, come back to us and ring 999, okay? Safety net the patient. Okay. I think that's it from my side. Do we have any questions? Yes. Can I ask about the smoking if he's not stable? You can ask about the smoking, right? But you can always say that I would be discussing this at the end once you're going to get stabilized, Mr. John. We'll have a detailed discussion about that at the end. Hello? Can you hear me, guys? Doctors?
Yes, we can hear you.
Okay, do we have any questions from today's session? I hope you learned something out of it, and maybe if by any chance, if it helps you score better, that would be something great, right? And make sure to be fluent, right? You need to be flawless. One thing I always tell you, right? Be flawless, right? Yeah.
Dr. Wajiha, you have
Yeah.
told us about psychosocial history during musculoskeletal pain. Can you repeat this?
Yeah, sure. So in the psychosocial history, in the musculoskeletal pain, it's very important that, Mr. John, do you have anything? Who do you live with? Do you have any help available at home? Or do you want me to contact, or do you want us to help you in any way by contacting the social services, right? And what do you do for a living, right? If the patient job involves lifting heavy weights and stuff like that, you need to tell the patient that, Mr. John, I can offer you a sick note for some period of time, right? You can show that to your employer. And once you return back to your work, right, we can also contact occupational health department. They can make some necessary changes at your workplace, right? And yeah, that's what you have to tell, right? This can be, yeah.